I'm Lorena Lombardozzi. I'm a senior lecturer in economics here at the Open University. And today we are delighted to have an amazing seminars and panel of speakers that will talk about migrant health workers and during COVID-19, in particular on the impacts, mortality and responses. I am gonna pass the floor to Nicola Yates, who is chairing social policy here at the Open University in the School of Social Sciences and Global Studies, who will lead the panel. And without further ado, welcome everybody. I'm just gonna say that we have a couple of points before starting the seminar. So the video is being recorded and will be available for playback after, so people who don't want to be featured can ask questions in the Q&A and has to remain anonymous. You are being automatically muting during the panel and talk, but please raise your hands if you want to ask a question at the end. And please follow us on Twitter at intdev_OU. So without further ado, I'll give the floor to Nicola, and thanks again for joining.
Okay, thank you, Lorena. Thank you very much. Good afternoon, everyone. Friends, colleagues, comrades, thank you so much for making the time to be here with us today. It's really good for our team, at least some of our team, to reunite around the presentation of our key research findings. So big welcome and thank you to my colleagues on the panel today, Sarah Tipping, Jane Pillinger and Genevieve Gentianos. And we're all going to present different aspects of our research project and its findings. So I should say that we are 4 of a rather large research team. There were 10 of us in total. That also included Vicky Murphy, Catherine Vaillancourt-Laflamme, Jihan Ismail, Carlos Montoro, Nashwa Ismail, and Blossom Carrasco. So some of those our colleagues will be able to join us, some of them won't. In any case, we were, I suppose, rather a large team. So I'm Nicola Yates, as Lorena introduced. I'm from the Open University in the School of Social Sciences and Global Studies, and my role is the principal investigator of the project. It's my great pleasure to also welcome our research partner on the project, Public Services International, in this presentation, as represented by Genevieve, who is the PSI Migration Programme Officer. At this point, I'm just going to invite Jen to say hello and just say a few words about what Public Services International is, who it represents, and a brief word about the work it does. And we'll surely hear more about PSI's work over the course of the next hour or so. Over to you, Jen.
Thank you very much, Nicola. It's a real pleasure to be here and to see the fruit of our labor for about 2 years, I imagine. With this collaboration between PSI and the Open University, we're very, very happy to be working with the team here that's so committed. And we've been working on this project in the first and second phase during the COVID times. So we were also facing challenges ourselves with regard to the epidemic. My name is Genevieve Gentianos. I'm the Migration Program Officer of Public Services International. We are the Global Union Federation of Public Service Workers, and we represent more than 700 trade unions, organizing around 30 million workers, men and women, in the public services. So all those public services from health, social care, utilities, local government, and different levels of government are part of our global union, and a third of our membership, that's around or more than 10 million, are in the health and social care. So this issue is very, very dear to us, and we're very happy to collaborate on this research project. Also including our members in the interviews and in the preparations of this research. So I'm glad to be here and I look forward to the discussion. Thank you. Over.
Over and definitely not out. We'll come back and hear more about that shortly, about that amazing work that you do shortly. So this is the title of our presentation today: Migrant Healthcare Workers During COVID-19, Impacts, Mortality and Responses, Collective Responses. So before I move on to say a bit more about the aims and scope of the research, I just want to spend a little bit of time setting out some of the context for this. So as many of you will know, migrant workers are of substantial and growing significance in many countries' health and social care systems around the world. So across the OECD, that one fraction of the rich world, the vast majority of countries rely on migrant workers to staff their health services and provide essential clinical expertise. So 1 in 4 practicing doctors and 1 in 6 practicing nurses are foreign born, and many countries outside of the OECD are also dependent on migrant workers to staff the health services and healthcare provision. So the majority or the dominant migratory trend in the health sector is from poorest to poor, sorry, from poorest to poorer countries and from richer to richest countries. So migrant health and social care workers are overwhelmingly recruited from poorer countries to fill vacancies in richer countries. So in many ways, migrant workers are of such strategic importance to population health, and critically also to the global goal of realising universal healthcare. And after all, as the Global Health Workers Alliance or Network argues, there is no health without a health workforce. Now, from quite early on in the pandemic, very early on in 2020, there was an emerging sense that migrant members of the health workforce were being disproportionately affected by COVID-19, and that COVID was promising, or actually was already becoming, evidently a women's rights issue as well as a migrants' rights issue. So the data sources telling us this were coming from, on the one hand, they were coming from small-scale qualitative studies, often set in single hospitals or in single countries. And on the other hand, they're also coming from health workforces themselves, whether through professional associations or through trade unions, in this case through PSI and its networks and its international affiliates. At the same time, the evidence base was patchy. There are many things that we didn't know without further systematic investigations. There's a desperate need also for a much stronger, more robust evidence base that would or that could speak to questions about the impacts of the pandemic on a more systematic, multi-country basis, as well as about the sorts of collective responses to the pandemic and the sorts of things that governments, employers, civil society organisations are doing or were not doing, and in particular the impacts of those responses and those inactions themselves. So there were quite complex processes and dynamics going on. So we were looking to untangle those and starting to really understand, the place of migrants within the health and care workforce and what was happening to them during that period. So the Open University and Public Services International, we received funding from UKRI to take that research forward and to feed into ongoing discussions taking place at sectoral level, at country level and at global levels. So I'm just going to move on now and just share with you very briefly the research aims and scope, which will give much needed context for what we will be presenting. So our aim were to, well, three aims really, as the slide says here: to give proper attention to the place of migrants in the healthcare workforce or healthcare workforces during the pandemic. Secondly, to respond to the need and indeed demand for a stronger evidence base on the impacts of COVID-19 on migrant health care workers, and to better track what sorts of collective responses were emerging and what were the pressure points on healthcare workforces internationally at that time. And relatedly then also to inform advocacy and planning around what sorts of measures could be instituted that would provide excellent protection for migrant health workers from the sorts of harms that they were experiencing. So that's the general kind of context of this. So today's presentation, just to run through this quite quickly now. So today's presentation, we're going to present some key findings from our project. We're going to highlight, so we're going to have 4 mini presentations, each of them talking about different aspects of the project. I shall start, we'll first do an overview of our findings around the impacts of the pandemic on migrant members of the healthcare workforce. Sarah will then follow on by looking specifically at the risks of mortality among migrant members of the workforce during the pandemic, present some data from there. Then we'll have a brief mini break, as it were, a chance for you to ask any questions that you want to, or any points of clarification. Knowing that in the meantime you can use the chat facility as well, and then we'll move on to talk about the collective responses to the risks. Jane will lead that, and then we will move on to talk about the kinds of labour advocacy initiatives that PSI with partners are taking to institute better protection for migrant members of health workforces worldwide. So that's our plan. I'm just going to take a little bit of sip of water before we move on. Okay, so let's start with the impact. So what factors affect migrant health workers' risks of infection, and in particular, infection and fatality during the COVID-19 period? And we're talking specifically about infection from and fatal outcomes of COVID. So our research identified 5 principal factors that exacerbate these risks, and I'm just going to run through these one by one. And I should say actually that all our research papers are the full research papers and a range of rather nice looking research fact sheets are all available on the project website, as well as from PSI's own website. So you can find these are all in open access, so you can follow these up later at your own leisure. So the first factor then that we found to be very significant is health workforce shortages. So it's been long known that the availability of a sufficient number of skilled and motivated health workers being in the right place at the right time is absolutely crucial for the effectiveness of any health system. The COVID-19 pandemic created an immediate and urgent demand for many more healthcare workers to boost surge capacity at a time of already existing chronic staff shortages. And those shortages were and still are the most severe in developing countries. So these shortages of health workers have put staff at a much higher risk of ill health in many different ways. So staff, as we found out through various sources have had to work far more intensively than they had to prior to the pandemic, working for longer hours, leading to higher levels of work pressure, stress and ill health, both physical and mental, including long-term ill health, including from long COVID. And that in itself has in turn exacerbated the shortages. And at the same time, these health workforce shortages have also constrained the capacity of countries to respond to the pandemic. So in many of the countries around the world, as the WHO itself has highlighted, it's the lack of available health workers which has proved the largest constraint to ensuring the continuity of essential health services during the pandemic, and that includes the delivery of various kind of tools with which have been able to combat COVID-19, such as vaccines, diagnostics, and therapeutics. Second factor is the recruitment practices that were instituted during the pandemic. So despite travel restrictions and border closures, many countries have accelerated their efforts to recruit internationally, that is, recruit health workers from overseas, particularly from poorer countries. So the UK, for example, is now recruiting from a list of more than 100 countries, some of which were off limits prior to the pandemic. So that's a notable change in this country's overseas recruitment strategy, and similar actions and policies were pursued in the richest countries around the world. So that in its turn has impacted directly on the health systems of lower income countries equally struggling with their own pre-existing shortages and pandemic needs. So there's been a kind of a further draining of vital human resources, assets from the countries which have been least able to deal with the pandemic and its effects. And the speed at which this recruitment was organised and took place also put those people migrating at a far higher risk of unethical recruitment practices. So, for example, in the case of Italy, the speed at which the recruitment of overseas health workers took place was such that many of the procedures normally instituted to give those workers full access to health insurance, which you need to access healthcare, weren't actually instituted. So they were actually denied access to healthcare themselves when they became ill. Quite often pre-departure information briefings weren't provided, so meaning that the workers, the health workers who were recruited arrived in their country of employment without knowledge of national labour laws, including their rights at work around health and safety, the right to organise and dismissal laws and so on. So they were, so their risks were, or their ability to protect themselves at work was obviously diminished. The third factor was decent work deficits, what we all know to be appalling working conditions. So many of these, many of the employment contracts, many of the contractual arrangements for work were incredibly insecure, either because they're on so-called atypical work or non-standard employment, such as fixed-term work, temporary work, and agency work, and so on. And also because those arrangements would prioritise labour flexibility, in practice meaning that, of course, the workforce were experiencing appalling working conditions, such as long working hours, lower pay, gaps in access or unable to access social protection, and of course being able to be made redundant far more easily. And the effects of these, we found the evidence suggesting that this is actually pushing migrant workers in particular in the health sector to accept unsafe working conditions. For example, working without PPE for fear of losing their job and other entitlements if they're refused to work, for example, on the COVID ward. So as one trade union representative that we interviewed from Asia told us, and this was in relation to Asian health workers working overseas as nurses, told us, quote, they can't say no to being assigned to COVID wards. Filipino nurses can't say no because they are worried about their job security, because they're on visas with conditions and short-term contracts. So the power that health workers might have enjoyed in other periods were severely limited. And there's a whole rake of examples of, or very particular egregious unethical practices that emerged during the pandemic, such as gravitating around, for example, repayment clauses, which limited people's ability to refuse to undertake work which they deemed to be harmful to their health, or indeed wage theft, that is not paying for overtime, and they surface as being particularly commonplace at that time. Third factor, discrimination, violence and harassment. And one of the appalling and devastating side effects of the pandemic has been the emergence or the intensification of racialized and xenophobic attacks and discrimination against Black, Asian, minority, ethnic health professionals and migrants more generally. And health workers, including migrant health workers, had encountered consistently high levels of stigma and discrimination, as well as verbal and physical violence and harassment, with the particular rather nasty interactions of gender, with race, and with class. So we see an absolutely spur in this sort of violence and aggression against migrant workers in particular, not just in one country, but across many countries. So this was systemic. The final factor is the absence of social dialogue and workers' voice, and this essentially means either not being able to join a trade union, that is denial of civil liberties on the part of some employers, many employers, meaning that migrant health workers were unable to express the concerns that they had about the conditions under which they were being asked to work, for example, concerns around occupational health and safety, or just being unable to refuse work that they regard as a serious risk to their lives or to the lives of other people's. And the deeming of health workers as essential workers during the time had actually, in many countries, denied some from being able to join a union or form their own advocacy organisations. So that's a very quick presentation of some of the underlying and principal factors which have actually contributed, which we found had contributed to the propensity of migrant health workers to be at risk of the severe impacts of COVID-19. Okay, so we will move on now, and I'm going to hand over to Sarah Tipping, who's going to talk a little bit more about the work that we were doing in the project around developing a methodology to ascertain the risks of mortality amongst migrant health workers in particular. So over to you, Sarah.
Hello. Yes, so bear with me while I share my screen and get my windows. Share. Slideshow. Right, can everyone see that? We all good?
Yeah.
You're muted. You can't say anything, can you?
Yeah, I can see it.
So yeah, so a key thing that we wanted to do. So a key part of understanding the impact of COVID-19 on migrant healthcare workers was simply knowing how many people within this group had died. This information had not been collated, not been reported, and it leaves a gap. So as part of this project, we tried to fill that gap by estimating the number of deaths. So ideally, we'd have liked to be able to understand the relative risks of COVID to migrant healthcare workers versus other healthcare workers. However, just due to the sheer lack of data, this wasn't possible. There was really little detailed information collected on healthcare workers, and even less on the migrant subgroup that would have allowed relative risk to be unpicked. So what we were left with is this challenge to try and estimate the number of COVID deaths for migrant healthcare workers using the scant information that we could get hold of. So a key thing that drove the approach that we did end up with was that we wanted an approach that could be applied to as wide a number of countries as possible. So this involved a bit of a trade-off, as some countries have better data than others. We didn't want an approach that might be incredibly accurate for one set of countries that maybe had better data, but couldn't be applied to others. We wanted to be as wide as possible. And it was also important to us to be able to use data that was publicly available and free, because we wanted to come up with an approach that could be replicated. So a lot of the data that we did use in the end was from global institutions like the International Labour Organization, World Health Organization, and World Bank. So first the thing we needed to review the data. So I'm going to tell you a bit about the data that we looked at. I'm just going to kind of scoot through this. But it was important because it impacts on the estimates. So the first step, review the data on COVID-19 deaths and morbidity, and whether this was available for migrant healthcare workers. Short answer was no. There wasn't any quant information out there. So then we looked at what information was available more generally on COVID deaths, healthcare workers, migrants, and the wider population, and how this information broke down. So in particular, whether it was available by age and sex. So it would have been too much of a task to look at every single country. This was a short, quick turnaround project, so we chose 4 countries. These were India, Mexico, Nigeria, and the UK. So just to mention that now that we were only looking at 4 countries. And we purposefully went for a mix of countries with higher and lower levels of migration, and with very different reported COVID rates and different data availability about health workers. So this allowed us to get a better idea of the data challenges, because this work was very exploratory. So back to the data inputs. Firstly, we needed information on COVID deaths. So there were 2 sets of COVID deaths that we looked at. They were reported deaths and excess deaths. So reported deaths are those deaths that were formally reported by countries and collated by the World Health Organization. They're like the official measure, as it were. Excess deaths were estimates of deaths that were generated by a range of researchers that looked at, or calculated the number of deaths by looking at how many people died during the pandemic, and the difference between that and how many people you'd expect to die in a normal year, as it were. So we used the estimated excess deaths on the World Health Organization, and this mainly because they covered the 4 countries we were interested in, and they broke them down by age and sex. So we used both deaths as the formal deaths. The reported counts quite often contained a degree of underreporting. It's partly due to differences in administrative capacity of the 4 countries, but also differences in testing policies, the ability to test, and so on. So the excess death count was generally higher. So once we had the information on deaths, we also looked at information on healthcare workers. So this was taken from the International Labour Organization, was available for most countries. However, information on migrant health workers was patchier. So this came from national health worker accounts, but was missing for a number of countries. But half of them had no information at all on the number of migrant health workers within them. So an early step was to try and impute this for countries where it was missing. So I'm not going to go into detail about the imputation now, but it is a reminder. So that's all in the rather lengthy methods report that accompanies this. But it's a reminder of just the extent which the key bits of information just weren't available. Finally, we needed information on population totals, but that was the easy bit. That came from the World Bank. So once we'd done the data review, we came up with a couple of approaches to basically estimate the number of people, migrant health workers who died. So we came up with two approaches. So we have the basic estimate, and this is generated by applying crude mortality rate to the number of migrant health workers. So the whole aim of the basic estimate was to estimate the number of deaths using minimum data possible. But we know that this basic approach overestimates the number of deaths because of the crude mortality rate used in the estimation includes deaths for everyone, including older people where we know the bulk of COVID deaths are. We also have the age standardised estimate. So this was our alternative estimate. So it does the same sort of thing in that it applies a crude mortality rate to the number of migrant healthcare workers, but it does this within age and sex. So this is trying to address the fact that the working age population should have a lower mortality rate than the overall population. So this estimate should be more accurate, and it is sort of preferred. However, it needs data. It needs information on COVID deaths, figures on migrant health workers and population counts split by age and sex, which was collected less routinely and not always available. Now, a massive caveat for our approaches is that these crude mortality rates are based on the general population. We've not been able to make any adjustment for the fact that the risks faced by health workers generally, but also by migrant health workers, are different to those faced by the general population. We didn't have the quant data to unpick the risks, so we know that they're different, but because we're unable to quantify that and say exactly by how much they're different, we wouldn't be able to factor that in. So we know this is a big caveat to our approach. And finally, we need to be mindful of the fact that migrant health workers aren't just a homogenous group, and within the population, their risk will vary. So having come up with those two approaches, we applied them. I appreciate this is numbers and a lot of numbers, and I promise you I'll guide you through them. So we did estimates for the overall health sector, but also separate estimates for doctors, nurses, and midwives. So these ones are for the overall health sector. And these are basic estimates based on reported COVID deaths. So I've included population totals, health worker totals, and crude mortality rates in this table, just to give some context as to where the numbers are coming from. So I'll talk you through the table. So first, we have the overall population on the left. So this is so the overall population, and we can see that India is by far the largest of the 4 countries that we picked. They then have figures on the healthcare sector. So we have the overall health workers, where India is still the largest, but you can see the UK isn't far off because we have a proportionally large health sector. And then we have figures on migrant health workers. So we have the total figures, and then we have, in brackets, I put the proportions. And you can see, as we know, that UK has the largest proportion of migrant healthcare workers within our health sector. We then have figures on deaths. So I've included the number of officially reported deaths, the crude mortality rate based on this. So this is just deaths divided by the population, and the estimated number of deaths per country for healthcare workers overall, and then for the migrant health workers at the end. So we can see that the number of deaths for migrant health workers was far and away the highest in the UK. It's just over 2,300, you can see at the bottom right of the table, followed by Mexico with 57, India with 11, and Nigeria with none. And we see that the UK also has the highest number of COVID deaths for health workers overall. So this is driven by 2 things. One being the relative size of the health workforces. So the UK is a major importer of healthcare workers, as we know, meaning the population of migrant health workers are going to be higher, and therefore the number of deaths amongst this group is also going to be higher. But we knew this was the case when we were selecting the countries. The other massive driver is differences in the level of reporting. So Nigeria in particular has a very low number of reported deaths, at just over 3,000, which results in really low mortality rate and a very low estimates. So this is the reason we looked at both reported and excess deaths. So I have a second table for you. And these are the basic estimates based on excess deaths, the excess death estimates. So this was to try and get around the underreporting. So figures on population and health workforce are the same. The differences are in the crew mortality rates and the estimated deaths. So the mortality rates of India, Mexico, Nigeria increase when we use excess deaths because these are far higher. For the UK, the number of reported and estimated excess deaths were actually very similar, so the estimates here barely change. So if you look at them again, with the UK, again, the highest, it's still around 2,300, so very similar to last time. But Mexico, India and Nigeria are higher. So Mexico is now 119, India 106, and Nigeria 13. So Nigeria is still low because of the very low proportion of migrant health workers.
Sarah, I'm really sorry to interrupt you, but we can still, most people are still seeing the first slide, I think, not the figures that you're discussing.
That's a bit rubbish. Okay, hold on. Has that been the case for everyone? Are you all stuck?
Brilliant. We can see the age, sex, standardized estimates now.
So you can see these now. So it wasn't.
I wasn't sure,
right,
perhaps
sure
you've gone into presentation mode. That's fine. We can see is that, yeah, those are the figures you're discussing, right?
Yeah. So have you not been able to see any of the others? Right. So I'm not. How best to do this? Look at that. So I just make this big, because I think when I go into slideshow, I lose you, and I don't know how to change that. Woo-hoo.
That's right. If we leave them like that, and then just as you move on with the talk, move to the next slide. Yeah, is that all right?
Yeah.
Thanks.
All right. I've now completely lost where I was.
Sorry.
Okay. Yeah. So I put together these sets of basic estimates. And the key point is that the estimates based on excess deaths are a lot higher than the estimates based on reported counts for India, Mexico, Nigeria, pretty much the same for the UK. So excess deaths, using that is useful in cases where we believe there's underreporting in the number of deaths. But there was an issue with the basic approach that I mentioned earlier, in that it can be an overestimate for the number of COVID deaths because the crew mortality rates include people over the age of 70. So that was our loose cutoff, for rather generous cutoff for working age population. And we knew the risks were higher if you're dying of COVID if you were over 70. So we did the estimates based on by including information on age and sex, and that's on slide here. So this time I haven't shown all the population figures. I just show the report, our estimates of deaths. So on the left are the estimates based on reported figures. So as with the basic estimates, the number of COVID deaths and migrant health workers is highest in the UK. It's just over 500, compared to 56 in Mexico, 8 in India, and none in Nigeria. So these differences between the countries are again driven by the relative size of the health workforce and mortality rates. But it's interesting to look at the impact of the age standardising by country. So in the UK, the age standardised estimate is much lower than the basic estimate. So the basic estimate for the UK was around 2,300, and now it's just over 500. However, the others don't change as much. Mexico dropped from 57 to 56, India from 11 to 8, Nigeria from 0 to 0. But these changes are because the UK has an older population, so the age standardisation has a bigger impact on mortality rates. So the other countries have younger populations, so there's less impact from dropping off this 70+ age group, because in the UK that makes up a large proportion of the population. So this was useful to know. This was useful to find out. So we did the same thing for the excess deaths, and that's shown on the right here. So the estimated number of COVID deaths for migrant health workers, again, highest in the UK, just around 850, compared to 106 in Mexico, 66 in India, and 24 in Nigeria. So these numbers are generally higher, because the excess deaths also tend to be higher. But there's something else going on in the UK here. So in the UK, the excess deaths had a different younger age profile than the reported deaths, despite the overall numbers being very similar. So this pushed up the crude mortality rates for the working age population and means a standardised estimate of COVID deaths amongst migrant health workers when using the excess deaths is nearly a third higher than that used in the reported deaths. So it's nearly 850 rather than around 500. And this is simply because the number of deaths in the working age population was higher. So flagging that the distribution of something deaths was something that we needed to be mindful of going forward. So I've bombarded you with numbers, but the kind of the key things was that this was a short turnaround project and a lot of this was exploratory. So the main aim was to identify, was it actually possible to make an estimate? Hence, we ended up with 4 lots of estimates, each with their own sort of pros and cons. So the exercise highlighted the lack of information available. There was no information on migrant health worker deaths, no quantitative information on migrant health worker deaths, very little on health worker deaths more generally, although better in some countries than others. In fact, things like getting information on the age and sex distribution of COVID deaths in some of the countries was difficult. So in Nigeria, we relied on information from a journal article. So there was just these massive gaps. There were loads of missing information on migrant health workers just generally. So half the country didn't have any information at all on just how many migrant health workers there were within that country, just highlighting again this lack of key information. And the quality of the estimates is very reliant on the quality of the wider deaths data, which obviously was very difficult for us to control. So there was a load of underreporting on COVID-19 deaths, which is obviously an issue, as that leads to underestimates for migrant health worker deaths. We try to get around this by using excess deaths, but need to remember that they are estimates and they have their own, often based on model data, so have their own sort of caveats around them. Despite this, there are some positives. The top line information was generally available, and then that made it was possible to generate basic estimates for most countries, which is why we've included it as an approach and not just thrown it out. Also, the fact that the basic estimate seemed less of an overestimate in countries with younger populations was encouraging, because those countries the countries that tended not to have information on the age and sex breakdown of deaths tended to be countries where the overall population tended to be younger. So this was kind of promising, because it meant we could fill in the gaps. And we do have information from most countries that are heavy importers of health workers, such as the UK, Europe, and so on. So generating estimates for these countries is a good means of estimating the bulk of migrant health workers across the globe. So there were a lot of positives that did come out of it. So it would be possible to kind of generate these estimates more widely. Finally, we archived the data we collected, so including the imputed figures for migrant health workers, as we felt this was like a useful data source for people. And we've on the project website, there are the spreadsheets that we use to generate the estimates. So the idea that people could use the collated data, feed in some of their own data and generate estimates for other countries, because we wanted it to be a tool people could use going forward. Right, so that's where I was for that.
Thank you, Sarah.
Yeah, and apologies that you missed half the slides. Because I had the slideshow up, I couldn't see the comments. So I couldn't see everyone telling me that they couldn't see it.
We saw some of them.
Apologies.
We saw some of them. We're good. Okay. Thank you very much. We're still pretty well on time, which is great. I can't see any questions posted in the chat box, but if anybody would like to or has a comment or a question, then do feel free to post it in there. We have some time at the end in any case for discussion and questions. So I think we'll just move straight on to our discussion of, well, actually, Jane's presentation of the policy responses part of the project. So I'll just hand over to Jane now. Thank you, Jane.
And can you see my presentation okay?
We can see, yeah, I can.
You can see it okay, good.
Looks good, Jane.
Great. Okay, so, well, thanks very much, everybody. And I think, you know, what Nicola and Sarah have identified is that, you know, we found in the project a huge disproportionate impact of both risks of ill health, of contraction of COVID and of deaths on migrant health workers. None of this is of any great surprise to the work we've been doing over many years on the rights of migrant health workers, who often are disproportionately affected by discrimination, by violence, by harassment, by poorer working conditions, by the undervaluing of their work, and in many cases working below their skill levels. But what COVID did was something very significant, because suddenly resources were put in place for COVID responses. There was huge reorganisation of staff to provide for critical care in particular, but there was a massive drive, despite the closure of transport networks, of all of the various infrastructure. As we went into lockdowns, there was still a massive drive for recruitment of international healthcare workers. And that recruitment was from the global south, which also was suffering from COVID, to the global north, which had a massive deficit of critical care nurses. So we saw this huge, I mean, we could say, you know, stripping of resources from some of the countries that are on the WHO's, the World Health Organization's safeguarding lists, where you're, you know, where there's a precautionary principle, where you're not supposed to recruit from countries that are, you know, of low or medium income, that have low levels of healthcare resources and low levels of staff. But we saw that being breached on many occasions. So what I'm going to do in my presentation, just very briefly, I've just got a few minutes on this, and I'm going to be passing over to Jen afterwards, who's going to talk about the trade union responses, is just to give a quick sketch of what's in the responses paper, which is really divided into two sections. One is around the national policy responses, and the second part is the international responses from international global organisations around global governance. So if I just, this first slide here, you can see, you know, the 5 main responses. The first was really to try and put emphasis on having ethical, fair and inclusive migration from countries of origin, particularly in the global south. And this meant balancing the need for the high demand of healthcare in the richer OECD countries with the healthcare needs of countries of origin, who also needed critical care nurses, but actually were losing them to the global north. Some countries actually tried to really put more emphasis on their international recruitment to make sure it was ethical, fair and inclusive. So England, Scotland in particular, updated their codes of practice on ethical recruitment, bringing them firmly in line with the WHO code of practice on international recruitment of healthcare workers, which is, incidentally, for those of you not familiar with it, is a voluntary code. It certainly doesn't regulate international recruitment, but certainly sets out principles of ethical, fair and inclusive recruitment, including reciprocal arrangements in countries where staff move from low income to high income countries. So we saw some of that happening, but the irony is, and it's not all as it seems, because there were some unethical practices, and we saw the UK, for example, recruiting from countries like Ghana and the Philippines, which were countries that were suffering also from COVID. And there was a kind of irony as well, because the UK had adopted, or Scotland and England and Wales had adopted these new ethical recruitment codes in line with the WHO code, and yet they were breaching the principles that have been established to not recruit from the countries, the 47 countries that have been included in the WHO's precautionary principles. Interestingly, in the Philippines, because of the concern of the significant exit of migrant health workers, the Philippines government actually stopped, for the first time, stopped international recruitment from taking place in order to make sure there were sufficient nurses in the Philippines. In countries like, if I take Zimbabwe, interesting because this was a country where there was huge outward migration at a time when massive inflation had meant that real salaries, which were low anyway, were losing their value. And actually, at the time during the pandemic, the vice president of Zimbabwe said to the richer countries that he was owed $100 million for the nurses who had been taken out of the country in Zimbabwe, and that this was a particular push factor because of the erosion of their salaries because of inflation. And in fact, Zimbabwe lost 20% of its nurses. And it's the first time we've seen this volume, huge volume of exit from Zimbabwe and indeed other countries in the global south, fueling an increase in migration. And it's actually been unprecedented. COVID saw unprecedented levels of outward migration. And indeed, those countries where there were vulnerabilities, we were still seeing that outward migration taking place and the protection measures not being implemented properly. So just in terms of just going around, I'm not going to cover all of the issues, but if we were to look at, for example, a trend towards bilateral labour agreements, which, in principle should cement both the ethical, fair and inclusive treatment, equality of employment conditions, of labour rights in terms of their adherence with international labour standards and so on. We see that they have been largely inadequate, often not transparent, but some BLAs, bilateral labour agreements, were signed as a response to the pandemic in some high-income countries, particularly for the shortage area of highly trained critical care nurses. And this is where we saw the biggest deficits then occurring in the global south. And then there were also some measures specifically about bringing in the whole, entry of students, of home nurses, of others, and to build self-sufficiency in some countries in terms of healthcare, of the healthcare workforce. In terms of some of the regulatory frameworks around entry and integration, these were relaxed in many countries, and it's interesting because often the recruitment processes are very long, they're very unwieldy, but actually it does show in a crisis situation, an emergency, how those can be speeded up to the benefit of the migrant health worker. But I think, as Nicola alluded to, some of these possibilities of having both ethical recruitment and indeed equality of opportunity and equality of social protection and so on were evaded in these processes to kind of skip into the system quickly. There were it's also interesting that there were quite a lot of diaspora and solidarity measures, and I'll just give Ghana as an example, because Ghana was a country that the UK and other countries were recruiting from. And yet a lot of Ghanaian nurses working in the UK and Ireland, in seeing the absolute, stretching of resources in the country around COVID, actually returned home to their countries of origin in order to support their home populations. In some cases, international travel restrictions were lifted for healthcare workers, and as mentioned in the Philippines, this was one area where we saw the Philippines government intervening to stop international travel because of the concern about the workforce. And then there were some issues also around working conditions and ensuring the retention of workers, and bear in mind in all countries across the world, and we saw this in the UK and indeed many other OECD countries, huge levels of burnout, stress, ill health, and many migrant workers continuing to work with COVID because they were worried about losing their jobs and indeed worried about their incomes. So there were lots of, initiatives introduced to help address some of the problems around the working conditions and around retention. In some countries, specific hazard pay was put in place. This was lobbied for by the unions in some countries and was successfully agreed in the Philippines, for example. Some income supplements. Some countries ensured, in order to get women back into the workforce to work in COVID, flexible working hours and family-friendly working conditions and working hours. Better systems of social protection were introduced in some countries. So, for example, the requirement for UK nurses, nurses travelling to work in the UK in the NHS, who had to provide for their own healthcare through private healthcare, these restrictions were lifted so that they could have access to healthcare within the NHS itself. Some countries put in place wellbeing support for workers because of the effects of stress, of burnout, of long working hours. But I think we found that many of those in countries of destination were culturally inappropriate, hadn't been made culturally relevant to the context, hadn't really asked migrant health workers what kind of supports they would need. But one of the things that was interesting at the time, and I think we saw this in many customer-facing and client-facing services, a very big increase in third-party violence and harassment. During COVID and during the kind of post-COVID kind of recovery period. And in the NHS, for example, and many countries across the world drew on the experience of ILO Convention 190 on violence and harassment at work to put in place policies to protect workers who were affected by violence and harassment at work, particularly from third parties, from patients and their families, frustrated by lack of services or indeed poor access to services. And then there was a whole lot, I mean, really interesting development for those of us working with the trade union movement. Huge increase in migrant workers being contacted by and supported by trade unions, much more solidarity amongst trade unions, and with civil society organisations, a bigger emphasis on advocacy, social dialogue and negotiating collective bargaining agreements, particularly around things like hazard pay, PPE, making sure that people had access to equal conditions of work when migration had taken place. So there were some big efforts for the first time in the unions. And in fact, I think it was, I'll just look at my notes here, because yes, it was 150 member states of the WHO. That amounts to 75% of the countries that are members of the WHO actually have been involved in some form of dispute with the trade unions, and some indeed with multiple disputes. And this came from discontent from many healthcare workers. In some countries, it came in parallel with the cost of living crisis, which kicked in later, but particularly in advocacy around decent working conditions, dealing with stress, anxiety, burnout, but also a key issue was ensuring adequate levels of staffing to cope with the pandemic. And we know in many countries, in rich and poor countries, staffing levels were inadequate to deal with this. In terms of international policy responses, I'll just go through these just fairly quickly. And these are grouped under really 8 main headings. So one part of this focus has been on building workforce capacity in the health sector. This has been ongoing from the WHO, but it's become even more urgent in the context of COVID, and particularly workforce capacity in countries of migration origin, particularly to ensure access to universal healthcare and the goals of universal health coverage in the UN Development Goals, the SDGs. The WHO, for example, issued its Working for Health Action Plan 2022 to 2030, which put a huge emphasis on building workforce capacity, investing in healthcare workforces, reducing the reliance on migrant labour to fill gaps on a temporary and urgent basis, but really building workforce capacity across the world. The ICN at the time said that the shortage of nurses is the greatest threat to global health. The ICN is the International Council for Nurses, the professional organisation for nurses. Various NGO initiatives have also been put in place across Europe and across the world, including the Pillars of Health NGO initiative, which has really focused on health workforce capacity. And then the second area has really been around this ongoing debate and policy development around the health worker mobility and migration, particularly starting with the WHO code, which is the code of practice on international recruitment of healthcare workers I mentioned earlier. Interestingly, just before COVID, the WHO updated its safeguarding list, and this is a list of countries that are affected by low incomes, but also poor access to health resources. And 47 countries were put on this safeguarding list with a precautionary principle that recruitment shouldn't take place from those countries unless there could be some reciprocal mechanisms put in place. That was in 2020, and as I mentioned, quite a few countries still continue to recruit from those countries on the precautionary list. In terms of working conditions, huge international policy responses were coming from the global trade unions, from the International Labour Organization, and particularly trying to build the support for COVID-19 to be recognised as an occupational safety and health issue, and to build better occupational safety and health protections for frontline workers, particularly in the critical care sector. The ILO added occupational safety and health to its fundamental rights of work at work. So this means that all of the occupational safety and health conventions of the ILO become fundamental rights which don't need to be ratified and are automatically applicable in all countries across the world in areas such as non-discrimination, freedom of association, and so on. The EU, for the first time, recognised COVID-19 as an occupational safety and health hazard and disease, which means that that would enable workers in the future to have access to payments and remedies on the basis that this is an OSH issue. There have been a whole range of skills programs, diaspora exchange programs, but there's also been proposals around global skills partnerships and so on. But effectively, I mean, none of them have really dealt with the issue about the lack of workforce capacity in all countries. And just building the skills of the potential of migrants to migrate into higher paid countries is not the solution, as is being proposed through the global skills partnerships. Another international response has been to build social dialogue and collective bargaining, and I mentioned this in relation to the International Labour Organization and bringing in these issues into global union dialogues. Key issues were raised at the international level about data monitoring and research, and I think, as you know, Sarah very eloquently showed us, the absolute lack of data, comparable data in particular, is really shocking in as much as we haven't really moved on very well from this in terms of monitoring the impact of COVID-19, of doing the research on the data and the trends. And I think this is also in relation to future pandemic preparedness. And there's been a lot of organisations across the world calling for us to review, monitor the COVID pandemic, to have better pandemic preparedness so that we're not having emergency responses without, and to address this in a strategic way. In terms of the conclusions, well, we saw a massive increase in recruitment, as I mentioned, at the height of the pandemic. Second, emergency measures on conditions of employment, of designating some as essential occupations, OSH recognition. However, they didn't cover all health workers. And one of the things that, I mean, I think we flagged in the research was the need to be looking at this not just in relation to professional qualified healthcare workers, but also in relation to the social care sector. And that would be social care of elderly people, disabled people, which is the sector where there have been the highest abuses. And during COVID, some of the biggest infringements of ethical recruitment and the rights of migrant workers. We need long-term policy measures on international migration because they're lacking, particularly around rights-based approaches and sustainable investment in healthcare. And this brings into play many of the issues that many of us have been arguing for many years, is that we need to be addressing this in terms of global social solidarity, and making sure that we have a global approach to health so that we can address global health inequalities and global policy and the impacts of neoliberalism in concerted ways. Overall, the measures on international recruitment remain limited, not least because there are no regulatory provisions in place. Of course, BLAs are important, but they're not transparent and not always inclusive of international labour standards, or indeed with the participation of trade unions. And as I mentioned, the WHO code is voluntary. What we would like to see ideally is a much more regulatory system so that some of the commitments on ethical recruitment and migrants' rights are adhered to in practice. And we need better data and a better post-pandemic assessment and review to establish, particularly if some of the acquired rights that were established during COVID, I didn't go into them in detail because we haven't got the time to do that, but giving people access to rights to healthcare and so on, and whether they were withdrawn. Were they sustained, or were they just temporary measures? We don't know that. And we also need this for learning for future health crises and future pandemic preparedness. So back to you, Nicola. Thanks very much. Oh, sorry, not back to you, Nicola. Sorry. It's just at this stage, I wanted to pass on to over to Jen, because Jen's going to talk specifically about some of the responses from specifically the responses from the trade union movement globally and the PSI in particular. So Jen, over to you.
Thank you very much, Jane. That was very, very comprehensive in terms of looking at the national policy responses and international responses over the years of the, rightly so, we're not really completely out of the pandemic. So what I'm going to show right now is what is PSI doing currently. You have reviewed some of the things we did, and in fact, many of the things we have done as the trade union movement, as representatives of workers' organizations, and ensuring rights for migrant health and care workers. So I will start my presentation. I will be talking about labor advocacy at present. What have we learned, and what are we doing right now and in the future? But I'd like to begin with a 3-minute video of the messaging that we got from this research and what we want to tell the world. Over to you, Craig.
Great, thanks Genevieve. Just bear with me 1 second, everyone. I'm going to play it straight from YouTube, so fingers crossed on the sound. Can you all see the screen? Can you give me a nod, Genevieve? Brilliant. Yes. Okay, here we go.
Strengthening migrant health workers' rights. Lessons from the pandemic. The COVID-19 pandemic impacted severely on migrant health workers due to their exposure to higher risk clinical settings, poor access to safety protection at work, and insecure employment. A rights-based, socially just and socially sustainable health worker migration governance is urgently needed. This can be achieved through fair and ethical recruitment. Laws must ensure migrant health workers are treated fairly and as equals, and that migration does not create shortages of health workers in poorer countries. Strengthening the rights of health workers. Workers' rights must be guaranteed by governments and employers. The World Health Organization Code, international human rights norms, and labor standards are fundamental to rights-based and socially sustainable migration policy in the health sector. Social dialogue. All policies and initiatives affecting migrant health workers must be agreed between trade unions, governments, and employers in countries of origin and destination. For this to work in the long term, social dialogue based on a partnership of equals is required. Only through rights-based, socially just, and socially sustainable governance of health worker migration can we realize the benefits of migration and mitigate its negative impacts? The time to act together is now.
Thank you very much. We don't need to see more deaths. We don't need to see more workers infected. We don't see more healthcare workers leaving the workforce. If we don't act on this, if we haven't learned from these lessons. And we have documented this in this project. We have even prepared fact sheets that are understandable because we need to communicate these messages to policymakers, to the World Health Organization, to health ministers, labor ministers, across society and across sectors to understand that we must learn from the lessons of the pandemic. And this is why I will just share my screen for my PowerPoint. Bear with me, please. Okay, yes. The example of the video is, it is 3 minutes, but it actually shows what we have achieved in terms of PSI and OU in better understanding, better documenting, identifying the gaps and challenges, reviewing what has happened over the last 2 to 3 years during the pandemic and its impact, its disproportionate impact on health and care workers. And so we brought those messages. And what I will be presenting in right now is the response from the Global Federation, the PSI, and its trade unions worldwide representing health and care workers, more than 10 million of them in the health and care sector. So we are continuing to build the trade union agenda, and we call this Power to Our Migrant Health Workforce in the health and social care sectors. I wanted to show this slide because, yeah, this is from our website. And every 18th of December, this is what the United Nations has declared as International Migrants Day. This is the day we commemorate the contributions, the situation, the lives of all migrant workers, regardless of status all over the world. So PSI dedicated the 18th of December 2022 in honoring our migrant healthcare workers. And that's why we said on this year's International Migrants Day, that was last year, we pay tribute to all workers who courageously battled the COVID-19 pandemic at the front lines, staffing our hospitals, delivering critical care, carrying out vaccination drives, and caring for our elderly family members. Yet they do all these very important works on the front lines, yet they are so invisible in terms of rights. And you have heard that from the presentations earlier. So what did we say? Public Services International and its affiliates stand in solidarity with all the migrant healthcare workers who are valuable members of our unions and our workforce. A fair, rights-based, socially just, and socially sustainable governance of health migration is needed for all countries to address the current global health workforce shortage. Pandemics, disasters, and the climate crisis, these are the challenges of our times. These will continue to put a heavy demand on our public services. In the face of these crises, PSI will continue to amplify the voice of workers, including taking to the streets. We see that, we continue to see that, and we will continue to see that until our demands are won. And to demand for adequate investment in public services and for decent work, safety, and social protection for all workers, regardless of status, who are delivering these services. And what do we mean by power? When we speak of power, PSI means POWER. P for public investment. Public investment in our health workforce. We need to invest in quality public health services so that our health workers are not forced to leave their jobs due to poor pay and dire working conditions. Unfortunately, we've seen so many of the health workers getting burnt out, fatigued, leaving their jobs. It's very difficult to recruit right now because of these conditions. And what is going on? Countries are relying on more reliance on international recruitment to bring in migrant healthcare workers who are also forced to leave their jobs in the poorer countries, in the countries of the South, because of the desperate conditions. What Jane has mentioned, what's happening in Zimbabwe, in Ghana, in West Africa, in Asia, everywhere. The health sector is a very, very difficult sector to work in, yet it is being carried out by very, very dedicated workforce. And as we said as PSI during the pandemic, we don't want to be called heroes. Our workers are professionals. They deliver care and health services, and we need to recognize this. This is our call, and we see this on the news every day. The applause is not enough. We need to see this in the real increase in pay, in working conditions, safety and protections for all our health workers, including the migrant healthcare workers who were so very much an important part of the critical workers at the front lines. So that's the P. We need public investment. Unfortunately, what we are seeing right now are austerity measures. After having gone through and seeing that actually governments can put in investment in the public healthcare system in a time of a pandemic, we are back again to austerity. We have the IMF and the World Bank dictating these conditions and privatizing our public services, and people are forced to pay, and health workers are not being paid adequately, still not being recognized. We need this, what governments are calling fiscal space. In the WHO, this is very, very much a big question, but for us, it has to be a priority public investment in our public healthcare services. O, organizing. The right to organize and to join trade unions must be guaranteed for all migrant workers, as stipulated in the United Nations and the ILO Migrant Workers Conventions. This is very important. We've seen how migrant healthcare workers who do not have a permanent status, or they're working on temporary visas, or recruited in a very precarious situation, they are afraid to join unions. But the unions are there defending and protecting their rights, and we need to organize more. We need to empower our workforce, regardless of what their migration status is. W, women. Women are the majority of our healthcare workers. Integrating the gender dimension into migration policies is critical to empowering women migrant workers. This includes reorganizing the nature of care work and integrating care into public policy and public services. It is not enough to say the care economy. This is not just of the economy. The value of care is very, very important, and it has to be it has to be integrated, mainstreamed in public services and public policy, because care is a human right for all. E, equal rights. Equal rights to decent work, fair and ethical recruitment, and social protection for all migrant workers. And R, the responsibility, sharing the global responsibility through international cooperation in the rights-based governance of labor migration, founded on the principles of solidarity, justice, and protection of human rights for all. So this is what power means. I just wanted to show you an example of how we organize. This is one of the campaigns we've done in the last years, and how we are winning this campaign, where we are claiming that no worker should pay to get work, that no migrant worker should pay recruitment fees. And we did this campaign for many years, and we have won this principle of no recruitment fees. It is now part of the UN Global Compact on Migration that, again, states should make sure that either through public or private recruitment, no migrant worker should pay recruitment fees. It has to be paid by the employer. And this was in many countries. We've run this campaign on PSI on no recruitment fees, and we also had this integrated and won in the ILO, International Labor Organization, and we have a guidance on this in terms of ethical of fair recruitment, and also identified what are the recruitment fees. So we have come from a principle of saying that no migrant worker should pay recruitment fees, to a campaign, to an organizing. All our workers rallied and lobbied governments on this. We got this into a UN governance and the UN Global Compact on Migration, the ILO, and the WHO. So governments are saying this, but of course we need to follow this up in practice, because we know that recruitment fees, exorbitant recruitment fees, lead to to workers getting into bonded labor and in very precarious and exploitative conditions, because they borrow money. Migrant healthcare workers, they borrow money in order to pay recruitment fees. And when they arrive in the country of destination, many of them are not able to join trade unions or to complain because they have to pay. We have seen that at least a month of their salary to pay back the recruitment fees that they have borrowed for. So just to summarize the slide that we've shown, what are we saying to the world right now in terms of health, labor, migration, governance? These are the key elements. Number one, fair and ethical recruitment, that the laws must ensure migrant health workers are treated fairly and as equals, and that migration does not create shortages of health workers in poorer countries. We continue to debate this at the WHO, and this is one of the things that the WHO Code of Practice is really saying, that poorer countries should not be drained of their critical human resources for health. And this is why what Jane Pillinger has mentioned in terms of now the WHO continues to issue these guidelines, which is the health workforce safety safeguards for countries that are experiencing critical shortages, that there should not be active recruitment in these countries. And if there will be a recruitment, that's the only caveat there is, that this it has to be ensured that there's reciprocity, that the country that's recruiting is also able to compensate or to ensure that there is adequate human resources for health in the country in the south. But of course, we know that that is very, very difficult. That's only a principle, but in terms of practice, developing countries, poorer countries are always on the losing end. And this is not an easy situation. That's why it's very, very important that workers are involved in both countries of origin and destination to say that, is there really a surplus? Because we do not think so. There are vacancies and they are not filled in because there's no funding to hire enough health workers, and staffing levels are really at dangerous conditions, especially in the poorer countries. Second, strengthening the rights of health workers. Workers' rights must be guaranteed by governments and employers. And we have the ILO conventions, we have the UN Migrant Workers Convention, and the WHO Code. These, the WHO Code, along with these international human rights and labor standards, are fundamental to a rights-based and socially sustainable migration policy in the health sector. And thirdly, the workers' voice, social dialogue, where governments, employers, and workers come together to tackle issues on equal footing. All policies and initiatives affecting migrant health workers must be guaranteed between trade unions, governments, and employers in countries of origin and destination. For this to work in the long term, social dialogue based on a partnership of equals is required. And all these key messages that I have shared with you, we continue to do this. And in fact, we have forged this in the next program of action of the Public Services International, as we are coming into a congress, a global congress for all our members and leaders in October this year here in Geneva. And as part of our work on migration, in the aspect of health worker migration, we are tackling this work moving forward, and perhaps it may be interesting for some of you of the work that we're doing and how we can cooperate in terms of moving these issues forward. So first is the global policy and advocacy. We represent health workers at the WHO, the ILO, and all the bodies, international bodies, including the UN Migration Network, which is the network of the different agencies implementing the UN Global Compact on Migration, and regional bodies such as the EU, Africa Union, etc. And we bring these messages in policy development, in raising our issues, and in bringing the workers' voice. For some of you, you may hear about the pandemic treaty that is now currently being debated at the WHO level. So PSI is part of the civil society and trade unions working towards putting in the proper language to ensure that, you know, in terms of pandemic preparedness, that there is respect for core labor standards, that there's respect for the right to health, and funding of public health services. So these are our key messages in the pandemic treaty, and this is ongoing work. It is expected to be finalized, the treaty. We hope that this is a treaty in 2024. So this is very much active work at the WHO right now. Second, alliance building with civil society and other partners. And this partnership with the OU is one example. And I'm trying to say to this is that it's very, very important. As global unions, as workers' organizations, we work closely with civil society partners and other allies. The example of this project is very, very helpful for PSI in generating the evidence base, in generating data, in generating and identifying the challenges, reviewing what has happened, and looking at where the gaps are that we can use for policy development and we can bring forward for advocacy at the national level, regional level, and international level. And also through alliance building, we can strengthen our work on organizing workers. And of course, organizing, and organizing. And we continue to do this to bring workers together in the health and care sectors and represent the voice of workers, including migrant healthcare workers, regardless of their immigration status. And lastly, enhancing the capacity of our unions to deal with healthcare worker migration and mobility in bringing social dialogue, the global skills partnerships, which is one of the things that's being discussed right now on how countries of origin and destination can build skills together in order to ensure that all countries will have the critical skills that are needed. But the discussion right now is lopsided because it's really just servicing the needs of richer countries who have shortages, but not recognizing what are the needs of poorer countries in the South who are also grappling with the same shortages and very, very critical human resources for health situation. Fair and ethical recruitment, when we say fair, that the conditions, working conditions, safety, remuneration, benefits, etc., are based on international labor standards, and ethical, that there's no poaching, there's no draining of human resources for health of poorer countries, and the bilateral labor agreements. This is a very, very new trend. We've seen the increase in bilateral labor agreements between countries of destination and countries of origin. We see the UK entering into various bilateral agreements with countries in Asia, for example, and in Africa, even including those countries like Nepal, for example, that are in the WHO health support list, the critical list. And we have to make sure as trade unions that we are part in social dialogue in looking at these bilateral labor agreements. At the global level, PSI was able to work with the WHO and the UN Migration Network. We now have a UN guidance on bilateral labor agreements where we made sure that there is respect for international labor standards, the core labor standards, human rights norms, and to make sure that there is social dialogue in any bilateral labor agreement. And forthcoming this year, we also push for the WHO to issue a guidance on bilateral agreements on health worker migration and mobility, bringing in all these messages and all these principles that PSI is advocating for. This is all to summarize what we have been doing and we will continue to do, and we are very, very grateful for this project, for giving us this cooperation and evidence base and helping us to argue our way in order to make a change. Thank you. Over.
Thank you, Jen. Thank you, team. Thank you, everyone. We somehow seem to have arrived at 2 o'clock, just barely blinking there.